coBRIM clinical trial compared monotherapy with Vemurafenib plus placebo to the combination of Vemurafenib and Cobimetinib. Cobimetinib is a MEK inhibitor, so this tested the hypothesis that the combination of a BRAF and MEK inhibitor would be superior to BRAF alone. The results have been published with the co-primary endpoints of progression-free and overall survival. But what is important at ASCO 2016 is an update of particularly the overall survival data, starting to look at subsets of patients with advanced melanoma treated on the trial. So the key findings that we'll be presenting from the trial is more mature overall survival data, with overall a median survival of 22 months in the combination therapy for Vemurafenib and Cobimetinib compared with 17 months median overall survival for Vemurafenib monotherapy. But of particular interest are subsets. We're starting to think about BRAF mutant melanoma in different prognostic categories related to particularly the serum lactate dehydrogenase, the performance status, the presence of visceral metastases, and in particular liver metastases. So one can start to make a composite of these various parameters. So what's very interesting is if you look at the low lactate dehydrogenase group, the overall survival appears excellent. The median is not near to be reached at this point in time, and even the Vemurafenib median overall survival is around 20 months. So we're expecting to have quite durable survival in patients with low LDH. If we look at the opposite extreme though, if the LDH is above 2 times upper limit of normal, and if that is accompanied by visceral metastases, then the median overall survival is only 10 months, even with our best combination therapy of Vemurafenib and Cobimetinib, and only 7 months with Vemurafenib. So these are two very distinct prognostic groups. It's very important because it starts to highlight the need for developing new therapeutic strategies, particularly in patients with visceral metastases with a higher LDH. But it also raises the very interesting question: do you choose immunotherapy or do you choose targeted therapy for patients with low LDH without visceral metastases? The overall survival really is extremely good now. We're seeing in patients with low LDH treated with Vemurafenib and Cobimetinib. So it is emerging that it's not so straightforward to make a decision to put patients on immunotherapy in that good prognostic group. And in fact, targeted therapy is a viable option as well, and both should be discussed with patients.